Welcome to the 2025 CMS Quality Conference. Please welcome to the stage Dr. Dora Hughes, CMS Chief Medical Officer and Director of the Center for Clinical Standards and Quality.
Good morning and welcome. I am Dr. Dora Hughes. I am the Chief Medical Officer and the Director of the Center for Clinical Standards and Quality. It is my great pleasure to officially open the 2025 CMS Quality Conference. We are gathered here today under a shared mission to make America healthy, improving health outcomes through prevention, quality, and safety. Now, for those of you who attend QualCon regularly, you are probably expecting our esteemed colleague, Jean Moody Williams, to be kicking off this conference, as she did from its very inception. She made the difficult decision, or at least I've been telling myself it was a difficult decision, to retire last year. And I know that you will join me in wishing her the very best in retirement. We will build upon her legacy and vision in the quality space, meeting her call to action to lift up the voices of patients, their families, and caregivers, to prioritize worker and patient safety, and to use the science of quality improvement to improve care and outcomes for all. Over the next 2 days here at QualCon, we will continue to focus on how to revolutionize our healthcare system, from transforming care delivery, to advancing prevention, to harnessing technology, and to strengthening patient safety. Whether you're in person or virtual, we are absolutely delighted to have nearly 7,000 quality experts, healthcare practitioners, technologists, data scientists, and patient advocates joining us for QualCon 25. I'm also excited to see so many of my CMS colleagues in the room. If you are from CMS or for another federal agency, we know we have colleagues from CDC, AHRQ, the VA. I want you to raise your hand. Wave it so everyone can see. Thank you. We are so appreciative of our federal colleagues. We know what they do every day for the American people. I also want to give a special shout out to those who helped make this conference happen and put together this amazing event. Because of time constraints, I can't say all the names, but I do want to acknowledge the core team of Captain Ron West. I can't see, please raise your hand. We have Shelley Coyle, Amir Al-Karani, Monique Indochetetro, Shalyn Quinn, Shawan Johnson, and Shatara Smith. Thank you, thank you. And for my office, I also want to give a heartfelt thanks to Ashley Spence, Cameron Ingram, Kara Abshar-Klein, and Leslie Arapi. My colleagues' actions remind me every day why I am so proud to be at CMS, to be part of an amazing team of people who are absolutely committed to ensuring the delivery of safe and high-quality care to all those we serve. Quality matters now more than ever before. Our nation spends more per capita than any other country, but our outcomes lag. The high prevalence of chronic disease, rising costs from fraud and waste, and an urgent need for patient-centered care all call for bold action. And further, a 2023 OIG report found that 1 in 4 Medicare beneficiaries experience harm during a hospital stay. And because patient safety is such a significant focus for this conference, I do want to acknowledge the passing of Dr. Lucian Leap, which we just learned. Dr. Leap was rightly called the father of patient safety, and he is rightly credited with starting the patient safety movement, teaching us the importance of a systems approach in tackling medical errors. as opposed to the individualized approach of blame and punishment. The nation owes quite a bit to Dr. Leap, and we, again, just really want to acknowledge his legacy, his vision, his commitment to patient safety. I would also note, I believe Leah Binder from Leapfrog is also with us here today. I can't see, raise your arm. She is continuing to live out his legacy as the president and CEO of Leapfrog, and we're hoping that you connect with her as well later today. Now, moving on to CMS a bit, we have a lot of levers and a lot of opportunities for impact. To set the stage, I always like to remind folks that CMS serves about 65 million people with Medicare coverage, 71 million people with Medicaid coverage, 25 million people with marketplace coverage, for a total of 161 million covered lives, or 1 in 2 Americans, and that is simply tremendous. CMS operates 27 quality reporting and value-based payment programs that cover most facility and provider types, supporting quality reporting from birth to the end of life and across all care settings. CMS provides health and safety standards for most healthcare and long-term care facilities, which serve as the basis for survey and certification. Our agency offers technical assistance and resources through the Quality Improvement Organization, or QIO program. And CMS also operates the nation's largest accountable care organization, or ACO, Medicare Shared Savings Program. And CMS supports more than 40 innovation models focused on improving quality and reducing costs. You'll hear all about this and more, the work done at CMS and the work done by so many of our partners, all here at this quality conference. We'll share success stories and set a data-driven foundation for urgently needed improvements in patient care and safety. Let me highlight 4 pivotal themes that you will hear that are embedded in CMS Quality Conference. The first is prevention as the bedrock for health. I'm sure all of you agree prevention is essential, not optional, to reduce chronic disease and healthcare spending. With US obesity rates soaring, rates over 40%, and life expectancy lagging, we must shift to upstream interventions. We must focus more on nutrition and physical activity. We must focus more on early screenings for cancer and chronic disease. The second theme is digital transformation and interoperability. Through recent requests for information, CMS has sought public input on reducing administrative burden and empowering patients and providers, which might include AI-driven reminders, telehealth, clinical decision support, and interoperable data streams that let patients engage and clinicians focus. The third theme is value-based, high-quality care and accountability. CMS is doubling down on quality and outcomes accountability, price transparency, and aggressive action on fraud, waste, and abuse. That means smarter payment models, real-time analytics, and enforcement to ensure every tax dollar is bringing high-quality care. And the fourth is care for vulnerable populations, from healthy aging to organ transplantation to community-based care platforms. CMS prioritized initiatives that help the underserved while improving outcomes. Over the next 2 days, our plenaries and sessions and our 5 tracks will dive deep into each of these themes, with focus on what is happening today in the clinical, long-term care, and community spheres. But more importantly, we're also going to focus on what needs to happen tomorrow and what policy, regulatory, and programmatic interventions can lead us there. We can't fix our nation's healthcare in silos. We need providers, advocates, technologists, data scientists, payers, patients, all contributing. And that's why your participation in the plenaries, breakout sessions, and hallway conversations is simply critical. Let's connect over quality reporting. Let's share lessons from hospital at home. Let's help shape the digital quality measurement roadmap together, and let's partner to embed AI at the bedside safely and effectively. Your commitment to elevating quality, preventing disease, leveraging innovation, and ensuring safety matters more than ever before. Now, at the heart of CMS' shift to prevention and our enhanced focus on safety and quality stands Dr. Mehmet Oz, confirmed as CMS's 17th administrator and set to lead our nation's radical healthcare transformation. A decorated cardiothoracic surgeon and former TV host, he now brings his energy, expertise, and public health vision to CMS. In his first few weeks, Dr. Oz outlined a bold agenda that's premised on prevention, digital transformation, accountability, and rooting out waste, fraud, and abuse. Today, he'll share his vision for making America healthy again, to inspire and to ignite the next phase of our quality journey.
Game time.
Please join me in giving a warm welcome to CMS Administrator, Dr. Mehmet Oz.
Very well done.
Thank you.
I get to sit with this wonderful woman fairly frequently now. She's a superstar at so many levels. I know many of you will interact with her, but I want to use Dora as an example because it is a blessing to be at CMI, and I'm often asked what's the most impressive thing or surprising thing that I've learned about the agency, and it's the quality of the people in it. And I say that very sincerely because, as you all know, I came from outside of government, and you hear all kinds of rumors about the folks that are working in government, but I can speak for CMS. This is an incredibly talented group of individuals who have deep domain expertise, and I have been blown away by their ability to get things done. God bless you. Thank you. So I jotted a few notes down, although I'm going to speak extemporaneously, in part because I've been up much of the night dealing with the reconciliation bill, which is making its way through the Senate. And many of the issues that are being raised by senators, and we'll be talking to congressmen as well, since they'll be next, hopefully, are the ones that should be concerning you. How do we actually get the healthcare system to function better? How do we get it to do the things that we had always assumed and believed were feasible? And I'm reminded often of the quote as you walk into the Humphreys building. How many of you have been in the Humphreys building, by the way? Well, most folks. As you know, it was built in the brutalist period. That's actually the name of a style, brutalism. It didn't last very long. It's brutal to look at. But when you actually are inside the building, the people, the space is a bit more attractive. But there's a quote on the left as you walk into the building from Hubert Humphrey, for whom the building is named. And it says it is the moral obligation of government, the moral obligation to take care of those at the dawn of their life, the children, those in the twilight of their life, seniors, and those who are living in the shadows. And that beautiful use of light as a metaphor. And of course, living in the shadows are those with disabilities, chronic conditions, issues that are going to hold them back perhaps physically or emotionally from doing the things they want to do in life. But there's always a chance you might treat them with success and maybe recover fully, maybe not. It doesn't frankly matter because we are judged, all of us, by how we take care of those who are struggling. How do we take care of the vulnerable among us? And we're a great nation, so we're going to do that. And that has been a resounding theme for the first few months of my tenure at CMS, and I want to emphasize that with you. And it's part of the reason I wanted to come speak to the largest quality conference on the planet, because what you represent here are ways for us to do all the different improvements that we believe are feasible. It's obviously hard. If it wasn't, it would have been accomplished already. But it's the opportunity and the challenge that I think many of you embrace. So I'd like to speak a little bit about my vision for how this might play out. And I want to emphasize that although we are because of the number of people we cover, as Dora pointed out, we will be the de facto leaders in the process. We have 2 ears and 1 mouth like everybody else, so we want to listen. And this meeting is important, not just for us to share with you our vision. And remember, there's a fine line between vision and hallucination, right? People have to see your vision if it's real. So our hope is to make this vision clear enough that you begin to to believe that it's possible, but we also need to hear from you. We need to learn from you, which is why the ability to bring 1,500 new friends into one space and 6,000, 7,000 more at home and many others who will watch us streaming in the future, what gives us a wonderful platform, but also an opportunity to start to tease out where the real opportunities lie. Now, as a physician, and how many of you are healthcare providers, by the way? Nurses, oh, quite a few, good. So you all know that the most expensive thing in healthcare is bad care. And so much of what we're trying to do, especially within the MAHA movement, is to get people to realize that they're part of the puzzle. If we can empower patients, then we'll be able to at least get our biggest allies to work with us to improve their quality of care. And MAHA fundamentally was many times about moms who are frustrated that it become very hard to become healthy. When you make it hard to be healthy, then people go in the wrong direction, especially if you offer roadblocks to that pursuit of a better life for their families. And so it is an inherent need, I think most of us feel, to begin to re-examine some of the fundamental decisions that our nation has made that has made it easier to be sick in America. And I want to, as a physician, do something that we're often forced to do, which is to speak honestly about the challenges that we're facing in this country. So I'll walk you through, I jotted a bunch of them down. We are, as you all know, dealing with a health financing crisis. It is related to quality, but they're not directly linked. Nevertheless, the number one increasing budget item in most states is Medicaid. Nationally, we are dealing with the reality that we spend twice as much per capita on healthcare than any other country. And interestingly, the numbers aren't getting better, which is a problem because we thought after COVID, much of this would revert, but last year, Medicare fee-for-service grew 9%. 9%. And we're looking at increases in programs like Medicaid nationally, where we've doubled our expenditures in the last 5 years, and they were still struggling to make ends meet. So if you have that much money coming into a system, you're not getting the kinds of results you want, then it starts creating additional challenges, especially when the number 3 cause of death in this country are medical errors and issues related to healthcare provision of our populace. So there are opportunities that are so large, it's hard to get your arms around them. But that's what makes it so exciting as a time, because we have tools and wisdom that's been accrued over the last certainly decade or 15 years that can allow us to take some opportunities that we historically couldn't have taken, because we didn't really think we could pull it off. I think now we have a generational opportunity to do just that. And you're witnessing a lot of this in our frequent announcements as we try to make changes. And it is a bit of a race. You have a limited period of time when you're at CMS, if you're coming in like I am for a 4-year window, to make these things happen. And it's imperative that you get as many folks to come along with you as possible so we can at least see what's feasible. Now, many of you saw last week we released the trust fund data for Medicare, and the prediction now that we don't have 10 years of runway, we have 7 years of runway. So we've lost 3 years. In fact, the worst case scenarios have the system going bankrupt, the trust fund Part A going bankrupt in 2029. Now, is that going to happen? Not if we can change that. But it's the people in this room that are going to play a role adjusting that, because if we can improve the quality, along with that, we'll improve the efficiency by how we offer the American people what we have promised them, which is a life of happiness and ideally longevity. And on that longevity front, we have not delivered. When I was finishing medical school, longevity in the United States and in Europe was roughly equal, and it stayed that way for another decade. But starting in the 90s, we began to diverge. And that divergence, if you follow them out, has now led to the United States having a shorter life expectancy than European countries by about 5 years. It wasn't that they got better, we got worse. So there are things that we can do that should be low-lying fruit that would ideally allow us to get back on the path to health and prosperity that is part of the promise that we offer each other. Now, it is a doctor's responsibility to share bad news, and we have that trust covenant, that precious relationship with our patients, and all health providers respect that. And I've just given you the raw material that we're dealing with. Now, the good news as well is that we usually have hope. And hope is a currency that we are, as a species, well versed in. But this is not false hope. There are real things we can do that will make a difference. And to get this agency functioning at full speed, we decided to adopt a couple ideas that have been historically used in the technology space, and large companies have adopted them, called OKRs. Objectives and key results. How many of you use OKRs in your businesses? It's about a quarter. It's worth looking into. And so as we made our OKRs, we made 5 objectives. The first objective, and the whole mission, by the way, was to be the best payer. Be the best payer in the country, be the best payer in the world, do things that move the needle on what it means to pay your bills on time and for high quality services. And that endeavor has resulted in us trying to break through on 5 major silos. I'm not going to cover them all, but the first one was respecting the fact that we have the opportunity to recruit the best people into CMS, to continue to allow the people who are already at CMS to thrive and to feel unbridled so they can move forward at the breakneck speed that's required to keep up with health transformation. So that is actually happening. And I do believe, although there definitely have been difficult times, and before I started as administrator, there had been some changes in staffing and the like, but we are now at a place where we are moving into growth mode. And I say that with a lot of confidence. We are going to start moving into a space that allows us to begin to develop and evolve and keep up with the rest of the country. So if you have ideas and you have opportunities, we're open for business. We want to interact with you. We want to play in the same sandbox, come up with better solutions. We want to take chances. We have a wonderful team that's powerfully engaged in this process. Some of them you'll meet on the stage today, but it's allowed us to change the dynamic, even sort of the speed limit of what CMS is willing to do. Beyond the people at CMS, there's also the fact that our biggest allies, the American people, patients and beneficiaries, have often been left behind. And it is our vision to empower these beneficiaries in ways that have only become available through the technological advances that now all of us are experiencing in banking and procuring food and watching streaming shows on television. All of these have dramatically changed our life, and we've taken that for granted because it came so effortlessly to us. It hasn't happened yet. That transformation, that digital move hasn't happened yet at CMS and nationally as it needed to. And you'll be hearing from a few panelists in a moment about where that's headed. But I think that also allows us to envision a different kind of experience for the beneficiary. Because if I have to say there's one thing that frustrates me about the job, I don't actually get to talk to the people we're taking care of. It's not easy for the administrator to actually send a note to beneficiaries and have them respond in any meaningful fashion. Despite the fact we've got tens of millions of email addresses, we theoretically have the ability to message folks, but because we don't have a relationship with them in any real meaningful way, besides those annual mailings and periodic updates, which don't really speak to the American people anymore, we're losing an opportunity. We're missing a chance. So we're not going to do that anymore. And it is our belief that we will have a minimal viable product available within a year that will allow us to talk to patients on a smartphone. By the way, Medicaid patients, folks who are having financial issues, 91% have smartphones. It's higher with Medicare patients. So we actually have the ability to communicate. We are now going to be able to evolve that process with you, because many of the people in the room, whether you're incumbents or insurgents, are going to be part of this solution. And our hope is to be able to cobble together a framework for a minimal viable product that at least speaks at that basic level to people. It will involve things like provider directories, so that we'll actually know where people are practicing. I'm told, I filled out my provider information to get my NPI number many, many years ago and never updated it. I'm probably the norm. I never thought about updating it. It didn't cross my mind. I was practicing at Columbia University in New York City, but I did have the right to do surgery. I'm a heart surgeon by training at other institutions. It just never crossed my mind to tell anybody that. And I suspect that I'm representative of many folks who, if I was queried, I would have told them, or I bet other people knew that because I was sending bills from those hospitals. So someone knew this information. We're going to pull that together in ways that allow us at CMS to build a base system. However, we don't want to build the ecosystem. We want to curate an ecosystem. And Amy Gleason, who's brilliantly come over from, she's the Acting Administrator of the United States Digital Service, DOGE Service. She's going to be speaking in a few seconds on the stage, and I want her to articulate this in her own words. But if we can build an ecosystem that welcomes people to come participate with us, then we're going to have access to data that we can make possible but won't own. It will have folks who are building better tools to communicate with the American people than we ever could, nimbly being able to connect. But if we can build the racetrack put the stalls in, the railing, put the sod down, and you are the racehorses, and we put you on the track, and you know it's safe, and you want to run, and you can build businesses around these issues, or help companies around you, or get your endeavor up and running more effectively because you have access to this. That's the best thing that could possibly happen for us. But when you build an ecosystem, you have to be a gardener, right? You have to be able to let people do things on their own, give them the freedom to grow and prosper as they feel best, and that we intend to do that. So that's sort of the basic foundation. In addition, we have the issue around providers. I don't believe we have done the best job possible for the people providing care in America. We have to incentivize those individuals to be able to do the things that they think are important. But to do that correctly, you need decision support for those individuals. You've got to be able to extend them, especially in rural parts of the country. It's quite challenging to find mental health providers. So if there are tools we can use, including AI and other modern technologies, which we'll be speaking about this morning, in a way that's not replacing the clinician, but allowing them to reach more people and support more folks with their wisdom, that's a good thing for overall. And for us to do that in a way that allows them within their workflow, while they're doing their job, to get the data that tells about quality into the system, that's even better. Then we're not having physicians spending half their time charting in order to make sure the quality metrics fall forward. And that's what I would call upon you to all challenge. Is the way we're gathering quality information today the best way to do it? Is it the only way to do it? Are there ways for us to talk to patients in a way that gets information from them that's invaluable to assessing the quality of the care they're getting, and to give them feedback so they become engaged in the process? Because if they know there's certain things that are not right based on what our understanding of their medical records are, and they've allowed us to do this, if assuming that they have not opted out, then how do we help them audit the program? How do we help clinicians do the same? And if we can do this in a seamless fashion, all of a sudden we get to become the convener, and that power to convene is important. And I'll give you a concrete example. Last week, many of you read that we're able to bring together the large insurance companies in America. They represented in the room about 75% of all covered lives in America, 257 million lives. And I want to applaud Chris Klump, who did the heavy lifting to pull these groups together. He's the director of Center for Medicare. And these folks voluntarily agreed to completely revisit and, if necessary, revamp prior authorization. Now, why did they do it? Thank you. And please do applaud the many folks at CMS who worked hard behind the scenes to make this possible. Why did these companies decide to come and do this? Well, part of it was because we said we're going to do something about it if you don't do something about it, right? Part of it was because there's blood in the streets, right? When you have insurance executives murdered in the streets of New York City, and the murderer is celebrated for having killed a man, and which is that LL Bean jacket that assassin wore sold out. So it spoke to the anger that people have about this process. It is the single biggest complaint we get. But prior authorization obviously also has an impact that can be beneficial if it's done correctly. So the insurance companies got together and said, we agree. We've got 15, 16,000 common procedures. We have maybe 6,000 that get prior auth, but only half of those are used by any one company. So we don't even agree amongst ourselves which procedures we should do prior authorization on. And we don't have specific rules about what quantitates successful fulfillment of the prior authorization process. Like what symptoms adjudicated would allow you to have a knee procedure done. And so if we can just get together as an insurance industry, they said to us, we could probably figure that out. And then they did it. They signed a pledge last week. Secretary Kennedy and I were at the event with them. We did a press event afterwards just to explain what they're up to. They have not done press. They're just doing the work. And they committed by the end of this year to be able to revamp prior authorization. And that includes some sophisticated ideas like if a clinician does a good job and you don't need to do prior auth on them because they're always doing best practices, make them a gold card member. They don't have prior auth anymore. We had some great entities in the room who don't do prior auth. They stopped doing it. Instead, they let their doctors do what they think they should do, and then they educate them through the process, nurses and NPs and PAs as well. And by doing that, they improve the quality of care at the back end rather than prior authorizing issues. And they're not seeing significant financial handicaps from that. But if you can imagine prior authorization like a credit card exchange, where you have very clear rules of what constitutes a successful adjudication of procedure, boom, you should be able to decide immediately whether something is authorized or not. And if it's not, you can go back and then deal with those small numbers of cases and figure out what the problem is. And this got everyone excited. And that's, I think, one of the ways that CMS can work, by bringing people together who otherwise would have been more challenged. Now, sometimes we don't have the luxury of calling people together. Sometimes it's a bit more forceful. How many of you saw the report yesterday from the Department of Justice on fraud in healthcare? About half of you. Let me just highlight, this was the largest action ever in our country for fraud, waste, and abuse. This is working with FBI, DOJ, DEA, the Office of Inspector General at CMS, at HHS, and what we basically said was $15 billion was attempted to be stolen from our country by mostly foreign operatives. These are not small-time operators. These are other countries attacking us. And why do they attack CMS? We've got the biggest bullseye on our back. The biggest bullseye. Why? Because we control $1.7 trillion of money. And you can access us by getting the numbers of a beneficiary. So these guys, scoundrels, were able to get 1 million numbers, begin hacking the system. They bought up DME companies and began to steal their insights, and move the leadership away, put their own people in there. And these are mostly, these had Russian links, were able to take advantage of the system. Now, thanks to Kim Brandt, who you'll hear from in a bit, who was the Chief Operating Officer at CMS, we only paid out about $3 billion, only. 15 billion was what was efforted. They stole about 20% of it. Once it leaves our building, we can't get it back again that easily. It goes to foreign bank accounts. So part of what we're doing with this digital transformation is to make it easier for CMS to stop down fraud, waste, and abuse. And some of it's fraud, waste, and abuse that's happening structurally inside of our system. We paid hundreds of millions of dollars of housekeeping fees. Again, CMS is not in that business. We're not in HUD. We're not going to build. I would agree that there are things we should do that are social determinants of health, but we have to also limit what CMS is able to do so they can actually manage the things that we're good at, the management of people's illnesses. I would encourage you to, as just one stat on the fraud side, 1/2 of the money we recover at CMS is driven by tips received from whistleblowers. 1/2. And 1/2 of all the money, more than 1/2 of all the money that the federal government recovers for fraud, waste, and abuse is from CMS and health fraud. So we are the biggest target, but we have the biggest opportunity to benefit from whistleblowers, which gives me tremendous confidence. Now, many of you know that this month, the last day of this month, is the 60th birthday of Medicare and Medicaid. And 60 years ago, when the agency was created, I don't think people realized how powerful and far-reaching it could become. As Dora highlighted with the numbers, we represent and protect now 1 in 2 Americans. As many other things that have come out of CMS and Medicare and Medicaid as was known back then. For example, the desegregation of hospitals in this country, Dora pointed out to me, was driven because it was a condition of participation that Medicare insisted on. And so there's many good things that come out of our ability to bring this many people together into one space. I would encourage you to think about that power as you revisit some of the ideas we're thinking about. It's not just that we'll fix this current issue of healthcare in America. It's the derivative benefits that we can learn about and improve the plight of humanity from what we learned here at CMS. Similar to, analogous to when you put a man on the moon, you develop the internet because it's on the way there. There are similar gains we're going to be able to learn from and benefit from and share with not just other Americans, but the rest of the world from what we learn. And it's the people in this room that are going to make this possible. So I thank you all very much from the bottom of my heart for taking time to be with us today and tomorrow. And we're going to be making a top-tier effort to make sure that you are completely included in what we're thinking about for the future of CMS. We're very transparent and very crisp and clear as we deliver those messages. So I want to introduce a video from a very close friend of mine that I've known for many years, but I've gotten especially close to over the last several months. Secretary Kennedy is, I think, the most passionate person perhaps I've ever met. He's engaged in every single thing that he focuses on, and those focuses are wide-ranging from falconry to understanding environmental threats to the well-being of the American people. But he's become a passionate supporter of what we're trying to do at CMS, and he's particularly desirous of us breaking down silos that often hold back large organizations from functioning correctly. So with that as a brief introduction, I'd love to have Secretary Kennedy address this group. He doesn't usually do this, but that's how strongly he felt about this conference. Secretary Kennedy, take it away.
Hey, everybody. I'm honored to be here today to address the largest health quality conference in the country, hosted by the largest payer in the country, CMS. The theme this year is Make America Healthy by improving health outcomes through prevention. CMS is uniquely able to influence quality and health outcomes because where CMS leads on these issues, the industry tends to follow. To really lead on this issue will take a concerted effort, and I am deeply concerned about the raw statistics. Medical errors are the number 3 cause of death in our country. Life expectancy has dropped 5 years below Europe's, and maternal mortality is the worst in the developed world. We have lowered our expectations from what we experienced in my uncle's time. I was a 10-year-old boy when my uncle was president, and physical fitness was one of his biggest preoccupations. My uncle's generation was part of a long parade of generations that saw Americans as the toughest people in the world. We had, after all, conquered the American wilderness through beef jerky toughness. We had won World War I. We had won World War II through the robustness of our people. And that's one of the reasons that he launched the Presidential Council on Physical Fitness. He would be very dismayed today to understand that 70% of American kids cannot qualify for military service because of health problems. Part of the problem is our food system. We are making it very, very difficult for Americans to be healthy. But the other part is our healthcare system. We have the greatest healthcare system in the world and the most advanced technology, but too often our care is technologically sophisticated, but our interactions with the American people are primitive. We can do a lot better by empowering our biggest allies, the patients and their families. When my uncle was president, we spent 0 on chronic disease. But today, 70% of our healthcare costs are going to pay for chronic disease management. I started the MAHA movement because I was alarmed by these trends that I was seeing firsthand in the decline of American health, particularly in our children. I had 11 brothers and sisters. I had almost 70 first cousins, and I know what a healthy kid is supposed to look like. And today, as I walk through an airport or down the street, I see all these children with chronic inflammation and mitochondrial challenges and anxieties and depression. I see these statistics about the declines in their fertility, and I'm not alone. I spent 2.5 years on the campaign trail, and my campaign was empowered by the passions of mothers who were seeing the same thing that I was seeing. There are 2 big health issues in this country, and one of them is our food. And we're doing our best at HHS to make sure that we can change that. The other issue, of course, is the quality of care inside the American healthcare system. Well, this is the largest quality conference hosted by CMS, so these next few days will shape the quality agenda for the country. I urge you to take this opportunity to speak boldly, to give us ideas about how we can improve this system for your patients. HHS is leading the way on these issues, but we need and want to hear your ideas. Together, we can make America healthy again.
He passionately believes everything you just heard. And he was so thrilled we were able to get this conference back on the docket, and we will continue to grow this endeavor. This is the 10th anniversary of MACRA. And we've learned about MIPS, we've learned about the APMs, we've learned a lot. Tools that now have become commonplace in America. The number of physicians on advanced payment models has increased. I think it was 125,000 people when the program started 10 years ago. Now we're up to about 750,000. It's remarkable how much people engage if you give them a bit of a nudge with a little bit of a vision for where they're headed. And with that in mind, I want to take you deeply into an area that we think is fundamentally important to this movement, and that is the digitalization, the digital modernization of CMS. It was initiated with an RFI that we put out, one of the first requests for information that we put out by Amy Gleason. I'd like Amy to come join us. She's strategic advisor and the acting administrator of US DOGE. With her, Brian Anderson, a physician, CEO of Coalition for Health AI, or CHAI, making the way out. Sue Sheridan is the CEO of Patients for Patient Safety. And finally, Sumit Rana is the president of Epic Systems. They're all joining for, I'm hoping to be an honest and maybe hard-hitting, we'll find out, discussion of what's going on with digital transformation. And Amy, I gave a very physician's perspective of what you were trying to do. It just fixed my presentation. What is it going to look like a year from now when a patient is contacted by CMS, and how is that ecosystem going to play?
Yes, so patients really should be able to have access to their data and be able to put that in an app of their choosing that can connect to all the different data across, and then connect to digital tools that the private sector builds. So CMS certainly has a part in this process of building foundational pieces that make this work, but really we're trying to empower the patient to have the tools that they need to get personalized care at any time, day or night. My daughter has a rare disease. She sees 12 doctors, takes 21 pills a day, and gets 2 infusions every month. And she's still processing and coordinating her care by filling out forms, making phone calls, and even faxing. And we need to stop that. So we need to get patients easy access to their data so that they can walk into a doctor's office, scan a QR code, and share their information. Or if it's late at night and they have a question about their care, that they could use AI to get answers in real time without having to wait for their doctor to get to call them back. So we really want to partner with the private sector to get this movement going and create that digital ecosystem.
Sue, what kind of barriers exist for patients, and how will the digitalization shift that? Or is this a false promise?
Oh, I think that some of the barriers that face us, and like Amy, I am a mom of a young man who has complex healthcare issues as well. And some of the barriers especially are the interoperability. I mean, that is, my son manages 8 or 9 different portals. They don't speak to each other, and that really is a patient safety issue, because at times, when the systems can't speak, Cal, my son, just had a medication error that, we fixed through digital health because, a doctor asked him to stop taking a medication, a seizure medication. Cal called me. I was here in DC. I went to ChatGPT, and it says, do not go off this cold turkey. I called my husband. He went on to open evidence. He said, do not go off this. My son went on to his portal, Epic. He was communicating with his Epic doctor, but his other doctor was on a different portal. So that doctor had no idea what was going on, that my son could not go off this. So I think interoperability is a huge barrier. Another barrier is access to something like open evidence, which doctors have access to. Why can't I have access to that? Why can't I have access to the same information that the doctors have? We have to democratize information for our safety.
You mentioned interoperability, which takes me to Epic. It's supposed to be a joke, by the way. I learned doing television that you might as well talk about the elephant in the room, because then people can get past it. I was told to me before I entered the agency that there were some groups of people I didn't want to talk to. I didn't want to talk to insurance companies. We have prior authorization, as a hope anyway, for the end of the year. I wasn't supposed to talk to the PBMs. We have a big idea with them that we're working on. These are voluntary. Yes, we know how to do legislation. We're doing it right now. We know how to make rules, but industry is more nimble than we are. And I come from the private sector, so I'd much rather have industry fix problems if we can. I was told not to talk to the big EMRs because they don't want interoperability. It's they're gaming the system. And I have not found that yet to be the case. Your coming here tonight is an example of that. I've obviously talked quite a bit with CMA at Oracle. There's other EMRs that we've been interacting with. We strongly believe that we can get incumbents and insurgents to both thrive if we build a safe ecosystem for both. So I'm going to put it in your lap right now. For the many out there who say Epic really doesn't want to do interoperability, and here's the 5 reasons why they don't, everyone's got their own bits of evidence. Why is Epic on the stage today, and what is your hope with this digital transformation?
Well, first of all, thank you for inviting us, and we want to engage. In fact, I believe we have a responsibility to engage. When you look at the types of issues health system faces right now, it's going to require a partnership between the government and the industry. And so we want to engage, and let's build a provider directory. Let's fix prior authorizations. Yeah. Let's improve the physician and patient experience.
Go to provider directory, because I know that you've made a commitment, I don't know if it's public yet, but I guess it is now, to help with this, which is something that Amy Gleason has a whole task force. And this woman is godsend to us. She's built a center of gravity for technology, IT in CMS. You know how many engineers CMS has? 13. 13. So we actually don't have even the manpower to do some of these things. We're desperately and aggressively hiring people to staff up in some of these areas. But these are the challenges that we're going to want to work with industry on. So how does the provider directory work? Give us an example of how you see that as an example of how industry can collaborate with government.
So a couple of things. First of all, I think between payers and providers today, they collectively spend about, I was told, $4.8 billion managing that. And when that is not a clean directory, it causes all kinds of downstream problems. In my role, one of the things, I'm a software developer by background, and as we look at what's causing a prior authorization breakdown, one of the things we see is that if the fields don't match, and the provider data is one of the biggest sort of sources for this, then those prior authorizations don't go through, the claims might not go through. So I think there's sort of three components to building an automated provider directory. First is to have this central directory and have this sort of concept of it's federated inputs from the different stakeholders, but there should be an unambiguous source of truth for each data element. So I think that's number one. Number two, it needs to, of course, have the governance to make sure it's of high quality. Otherwise, folks won't be able to trust it. And then third is, it needs to be automated. It needs to be operating in a way that there can be machine-to-machine communication that both reduces human workload, it also reduces human error. Otherwise, we'll be back to step one.
Yeah. It's these broad and big visions that I think we have to act on, and you have to take chances and go after these kinds of big targets. Brian, so when I met with the insurance companies last week to talk about prior authorization, and these are very honest conversations, so sometimes they can get tense. And so we're saying, what is actually going to hold you up from fulfilling your promise to the American people and to us that you can actually address this prior authorization crisis? And they said, sort of sheepishly, and they all said the same thing, 49%, it wasn't 50, it was 49% of doctors respond to prior auth requests with paper, which is stunning to me because I guess I'm suspecting 85% of doctors have EMRs. So what's going on, and what do we need to do to get my brethren and yours to start to use digital tools to interact with things like prior authorization? We did it with e-prescribe, right? So why can't we do it with prior auth?
So I think it's a great point to bring up. In CHI, what we're trying to do is bring together both the health systems, the providers, the doctors and the nurses, and the payers to come up with a consensus set of best practices that they can agree to. And using digital forms for these prior auth is a great example of, providers should get the buy-in to use those kinds of forms. To Sumit's point, having easy access to the complete medical record and the data that's relevant to be able to make and adjudicate a pre-authorization determination rapidly and quickly is also important. So our work in CHI is really focused in bringing together the private sector stakeholders, so doctors, nurses, patient community advocates, and the payers, to agree on how do we do this right and how do we do it quickly. So some early things that we've learned. The payers are, I think, very willing to think about using AI to adjudicate claims where it's approved in real time. So imagine a future where you have providers that have bought into this idea. AI is being rapidly used to say, yes, that patient can get that surgery, can qualify for that medication. That's a real incentive to get the buy-in that we need from the providers and the payers to use AI responsibly.
Amy, jump off that springboard and address or share your vision for how AI could actually transform the system.
Yeah, so I mentioned my daughter that has this rare disease. So recently she was denied for a clinical trial and it appealed twice and still didn't get in. And so she loaded all of her records that she had into AI and said, what other clinical trials might I be eligible for? And it came back and said, actually, we think you're eligible for the one that you were declined for. And she's like, why is that? And it said, well, actually, I think you were slightly misdiagnosed 15 years ago. It's a subtle difference in her diagnosis, that didn't really affect her treatment through this time, but it was probably more mainstream and easier for them to document and for her to get treatment. But it turns out 15 years later, this slight difference makes her eligible for a clinical trial. So now she's going back through that process, and it's looking very promising. So by giving patients access to their data and being able to use AI and modern tools on top of that, you can really unlock a lot of potential for patients. But the key is that you really need to have that data for AI to really work. And so that's why CMS is really focusing on so much of this foundational infrastructure, including provider directory, to be able to make that happen.
Sumit, what role should CMS play to help you? And just to follow up on this other question to Amy, how is AI going to change how Epic does business?
Well, so first of all, I just had my physical. And so I got to see this.
Backstage, or?
What's that? Well, I just turned 49, and 3 body parts broke within 2 days. Anyway, I was at my doctor's, and I actually did what Amy mentioned. I used AI, first of all, to take my record, and I asked, what should I be asking the doctor? It was quite interesting, and I had a good list of that. And then my physician experience was that as I got there, the physician and I were seated 180 degrees with each other, like looking at each other. The computer was on the side, we didn't look at it. He said, I'm going to record our conversation, asked for my permission, recorded it on the phone. And then when we were done with our initial conversation, then he brought the computer screen, and we went from 180-degree mode to a triangle mode. I'm a mathematician, if you can make it out. And then the conversation had come back, and then he walked us through. And it was really magical to sort of see that experience. And at Reed Health in Indiana, one of our customers, they found that by doing this type of an AI-based charting, the doctor documentation time went down by 86%.
Wow.
86%. And I certainly sensed that myself. And at another of our sites, John Muir in California, provider turnover went down by 44%. And so what we hear about this technology is it's great. Apparently it's saving marriages. And doctors say, I love it, and don't ever take it away.
You know, to that, I was at a conference similar to this, and a clinician was being talked about by her husband. And he said that his wife was home for dinner, and the kids asked why mommy didn't go to work today. And the father told the kids, well, mommy did go to work. And they said, no, she can't have gone to work because she's home for dinner. And he said, no, she has a new AI system in the office, and she's going to be home for dinner from now on. And I can speak, maybe Brian, you and I can probably, all the clinicians in here, none of us went to medical school to chart. It's the worst part of our jobs. Every job has bad parts. Work is work. But in medicine, it's very, it strips away your belief that what you do matters, which is why with your observation, I'm hearing about that more commonly. Do you have any idea what percentage of practices are doing that, and what would be the obstacle to becoming nationwide? Is that something an EMR could routinely offer?
Yeah, I think it's that AI charting is very rapidly expanding. Our sites have dozens of these different type of feature sets, and that, by the way, is just one example. Another example is that AI can also summarize the chart prior to the patient, and that can sometimes both tee up certain things that perhaps might get missed because you're seeing patients in sort of rapid increments, but also it allows sometimes a provider to be able to dig into certain things with the patients. So I would say about close to 80% of our sites have some sort of AI already up and deployed. And we have about 100 more of these AI tools sort of in the pipeline. And so I think this will become very rapidly dispersed.
Sue, do patients trust AI? I mentioned earlier that we want to give patients the right to opt out. How many will opt out of a system that is using AI or more sophisticated information technology tools to adjudicate what you should know about your medical record?
Well, that's a good question. I was just talking backstage about a report that came out just a couple weeks ago. It was an international study on patients, and of the 15,000, I think it was, patients, half of them were supportive of AI. Now, there are different demographics. I think what will get us to trust AI even more is if we're engaged as partners in the development, the oversight, the governance of AI. We want transparency, we want privacy, we want to make sure this is safe. So that's something that we hope that CMS, if they are paying for interventions that include AI, that it undergoes rigorous studies to ensure that we're not guinea pigs.
And what about for physicians? Again, the reason I was told physicians, back to the point about 49% of us actually responding with paper, the reason I was told that they don't use their EMRs is they don't trust the insurance companies. They think if the insurance companies have unfettered access to our data, then they'll use it against us. So where are doctors on this? Right.
I mean, I think that's right that they have a concern about the use of the data in a way that isn't for the benefit of their patients. So full stop on that one. As it relates to AI, I think the general trend is it follows a lot of the national surveys that are out there. The majority of providers don't trust the use of AI in high consequence use cases. Mm-hmm. And I think there's concern about, is it going to hallucinate? Is it going to come up with the right kind of diagnostic accuracy that, a referring clinician might be able to help if that provider is part of a care team? In CHI, when we talk to providers, I would say that the journey to building the trust that we all want to have, to unlocking the potential for the use of AI to save people's lives, be it in the ICU or in managing chronic diseases, starts with working, just I think as Sue said, working with patients and nurses and doctors and the technology companies to bring them together to help come up with a common definition of what does the good, responsible use of AI look like, and then accelerate the kind of innovation that we want in those spaces. So ambient listening, I completely agree. As a physician, that is fantastic as an emerging capability that many hospitals are adopting. But that's, I think, to the benefit, we would agree, mostly for physicians. We're able to turn away from our computer screen and finally look our patients in the eye. The space that really excites me moving forward, that I think many doctors are going to begin to viscerally feel, and their patients are going to be able to appreciate the outcomes, is in the space called agentic AI, where you have AI agents that, for those of you that aren't familiar with that term, it's essentially an AI tool that operates in a semi-autonomous way, operates as part of the care team, working as like a co-pilot with a physician. When you have AI tools that are never going to grow tired, always going to be as empathetic and listen to their patient and be able to meet them where they're at, be it in rural Appalachia or in the heartland or in an inner city somewhere, and be able to take the data that Amy and her team are making available and have the kind of diagnostic accuracy that Sumit is describing to manage diabetes, to screen patients for undiagnosed diabetic retinopathy or hypertension, and really deliver high quality care to those individuals. I think that is going to be a turning point. That's going to be a watershed moment we are right upon that. We're seeing some evidence of that across a number of startups in the space within CHI right now.
Amy, let's continue that same theme. We've spoken to the largest AI companies on the planet. They all assure us agentic AI is here. And I can imagine as a clinician it benefiting me, because if I see someone at 6 p.m. with a cough, I don't have to figure out how to schedule an x-ray with their insurance company and get the results, get the sputum test done, blood tests, it could just be done for us. So it could get that mom home for her kids and the agentic AI would respond back. How does CMS include agentic AI and those types of tools? Do you have use cases in your mind as you think about this, maybe for rural care?
Yes, so as I mentioned earlier, I think if we can unlock the data from all these different systems and give it to patients and providers, then we can use things like AI to help patients have conversations. It can be an augment to primary care, especially in rural areas where there aren't enough physicians to see patients. And so, and as we build trust with patients that this is valid, then you can really have access to these tools for prevention and for helping you guide. My daughter sees her main doctors like every 3 months. So having something you can have every single day that walks you through how to be healthier, and if you're having a symptom, is that because of a medication or is it something else? Is it important? Do I need to see the doctor? It can really help you 24 hours a day. And as Brian said, doctors and nurses get tired, but AI doesn't get tired. So it can help you learn how to dose your insulin as many times as you need it, or help you figure out which foods are helping you spike your blood sugar every day, all the time. So I think it's a big part of this digital ecosystem that we're building.
What keeps you up at night when you think about how to unlock the data? Now that you have the promise of tools like agentic AI, the risks, the penalty for not unlocking that data becomes even greater.
Yes. So that's really why we made the announcements that we did last week. I think CMS really needs to be the foundational infrastructure tool so that the private sector can really take off. So as we talked about, the provider directory, we think is a big part of that. So right now you can't really find where all the data is. So if you're gonna figure out how to connect with providers, you don't know an easy place to find what networks they're in or what their FHIR endpoints are. So that's why we're starting our provider directory work with this interoperability focus. But it also should be which insurance plans they take and which offices they are, and everything that we know about a provider to be able to help with care coordination and driving things as well. And then digital identity is another piece, so modern digital identity tools. We committed to adding that to Medicare.gov at first and to other applications later. But using digital identity to create that TSA PreCheck for healthcare really makes it easier for our providers to be able to share that data and trust that it's going to the right person, so that the patient can have it and the provider can have it as well. So I think to get data unlocked, we really have to start with those two things. And then CMS has to set an example and expand our data sharing through APIs, and also agree that we'll participate in trusted exchanges. And by us using them, we'll also see where the challenges are and can help unblock those as well.
Sumit, how do you see this from the EMR perspective? Speak for the sector. What do you want government to do to help? What would government muck up if it got in the way? What are the things that concern you as you begin to engage the digital modernization of the country?
I think it's a good thing. I think there's some infrastructure that's needed. I think provider directory is one infrastructure we've talked about. I think another one is to have the rails so that everyone has at least a sort of a floor, a minimum level of connectivity. I think TEFCA can serve that. There are a couple use cases that are already up and running on TEFCA. There's the provider-to-provider interoperability. We just did our work to also open up the IAS individual access service. So that's, again, what will allow individuals, patients to access. I think the next thing that could be also done is to start to look at payer-provider type of interactions on that. Should there be a required response type of use case for claims and claims payments, as an example? And I think all of this infrastructure would help, in my mind, sort of have that exponential growth, take what is possible technically and make it universal.
So just to throw an idea out there, how far are we from being able to have the doctor just take care of the patient? The charting is done independent of MIPS or any kind of quality metrics. And Brian, I'll come to you with this and maybe back to me. And just have that be enough. Because frankly, if you have a risk factor that you're not treating, I'm not sure that it should make much of a difference in reimbursement. And sometimes there are risk factors that are harder to quantitate that have a lot of treatment associated with them that should be compensated better.
Yep. So I think we're very close. AI has the potential to unburden so much of the workload that providers and nurses face right now, be it documenting all the different diagnoses that they want to be or need to be reimbursed on. I think, with your leadership in CMS and I think the focus and looking at the value-based care space and how we align the use of these AI tools, the use of technologies like ambient listening in a value-based care setting, driving towards real quality improvement and outcomes, I'm really excited about the next 3-4 years, about where we're going to go in the emerging use cases and capabilities of AI in that space.
Sue, the missing link I mentioned in my opening comments was our ability to speak to the American people, to the beneficiary. And we are thinking about how to do that. I'm going to have Amy tell a little story about Blue Button 2.0, if there are any similarities between now and then, because this is her fault. But it was a great advance when it happened, and it offers us some insights on what might happen now. But if you're trying to think about the average beneficiary, what do they want to hear from government about? What do they want to hear from private vendors who are making apps let's say they're a 75-year-old diabetic female who still has her husband around. So she's managing herself and him most likely, and other family, but her diabetes and herself. What does that look like? What would you want that to look like a year from now?
Well, I would have to put it in the position of like managing my son. He's a dual at Medicare and Medicaid, and so there is a total disconnect right now between us and Medicare and Medicaid. I mean, I would like it to be bi-directional, quite frankly, not just to hear from Medicare, Medicaid, or Medicare, but I would like you to hear from me as well. And so, like, to hear from you, I would like to hear things like, how do I manage 9 different portals? How do I manage medication management? How do I make Medicare aware when things don't go right? I mean, I think one of the biggest concerns I have in our healthcare systems is misdiagnoses. Misdiagnosis harms or kills 800,000 Americans a year at a cost of about $800 billion, according to the OECD. So I want you to hear from me about that, but I also want you to help me prevent those diagnostic errors, equip me with information, equip me with AI, equip me with the autonomy and the agency that we all need. Make me aware of those digital tools, help me pay for those digital tools. And so I think that what I would like to see is this bi-directional between Medicare and the beneficiaries, because we rely on Medicare so heavily.
Yeah. And are you okay with it being text form? Would you prefer video, chatbots, avatars, or does it not matter?
Yeah, I think it would matter per patient. So I think you're going to have to offer all of the above. Like, for example, my son is speech impaired, so he would want to do it via text or something very high tech. Matter of fact, he uses AI to speak. So we need to think about our patients out there that have speech impairments. Let's give them AI to speak. My son uses Murph AI with his clinician. So we have to really think big about how we're going to communicate. And my 92-year-old mom would want to communicate in a different way than my 30-year-old very tech-savvy son.
Now, I was talking to a very innovative female physician doing actually dual eligibles, and she says the 2 biggest predictors of cost and quality, because they are linked, are not having another person in your life, loneliness, because there's no one to double check. The second issue, which is you don't read English well. It's not that you don't speak English, you don't read English well. So you get a long document that's hard to translate into the usual human language, and you're struggling now. And so those are both areas that I do think we can make some headway, and the bi-directional nature of this matters. Yeah. Amy, take us back to 2018. Blue Button 2.0 is coming out. What are the similarities between what happened then? It was a very a grand vision that you had, which did accomplish a lot, and what's happening now?
Yes, so we really wanted to give patients access to their data with Blue Button, but the challenges we ran into are that most patients didn't have a Medicare.gov account and weren't digitally engaged, and so the providers really started off very excited about this and trying to help patients get connected, but then they would realize they had to help them sign up for a Medicare.gov account, or they might have forgotten they had one and didn't have a password. So it really took a lot of effort to get them started, and that's one reason we're so excited about the modern digital identity tools, because they can really do that one time, and when you sign up for Medicare, you do it through Social Security, and they have modern digital identity on their site, so they could use that same credential at CMS or at IRS or anywhere else they go or government services. So that should help a lot. But then it really, like, once you got that information, you just kind of had it in an app and you couldn't really do much with it. So now with so many more capabilities in technology and with AI, we can really offer them something to do with the data once they get it. Mm-hmm. And one of the things we want to do is when they're in Medicare.gov is to have like an app store so they can see which apps are recommended for them. Oh, you have diabetes? Have you seen these diabetes apps, and helping them know that these are at least been verified to be secure and safe, and let them know that that's there. And then the other one is to really be able to communicate directly with them, so be able to push information to them, whether they're at Medicare.gov or whether they're in one of these apps from the App Store. We want to have a connection in these apps so that they can also get communication from CMS and communicate back to CMS.
Sue, does it sound good?
Sounds good. It's a start. Yeah.
This is why I love this one. I can understand what she's saying. I speak to technologists sometimes, and I'm not quite sure I got all the pieces, But that's a vision that I can see too. And I think we can act on that. And there's so much else that it'll allow us to do. And I touched on fraud, waste, and abuse as another example. When the DOJ is telling me that 1/2 of all the money we recover is directly linked to whistleblowers, that's powerful. That means the bi-directional discussions we mentioned, that means a lot to us. So Sumit, you probably have access to a ton of insights that could help us identify when people are doing the wrong things. I'll give you 2 cases that came up yesterday. There was a cardiologist in Nevada and Georgia seeing a patient at the same time, in person. Hard to do, right? So it's sort of a wake up, to the system. This may not be right. A bigger problem than that. We'll figure that one out. That was a systemic effort to defraud us. But the bigger one that I was worried about, there was a clinic that was billing millions of dollars for skin substitutes. The clinic was a psychiatrist clinic, mental health clinic, and they were paying an anesthesiologist to apply the skin grafts. None of that makes sense. Somewhere along the line, they were using an EMR to generate bills for us. So how does Epic and other major EMRs look at fraud? How do you get engaged in that process? What's the best way for me to call and say, do you have any clues for our war room, which Kim Brandt created with Amy and others are being supportive of? How does that look? Just paint me that picture.
Yeah, I think there's things that can be done on both sides of that equation. I think in the EMRs, one can build decision support to look for things that might be wasteful and tell folks that perhaps this is not needed, or that you're about to order an MRI, but the patient just had an MRI, and I've had it once. I don't want to go into that tube anyway, right? So from a patient standpoint, it's a good thing too. So I think there's things like that can be done on the EMR side. I think I keep coming back to the provider directory. I think it'll also help because having NPIs and having accurate addresses so people aren't utilizing those for other purposes, I think that's an important part of the equation. And then I think there's a waste side of this too, both on the provider side and the payer side. I've heard as much as 30% of time and energy spent on what's ultimately waste. And if we can connect the systems to do, to make that better, you both reduce that waste. Not to mention, patients get access to care earlier. That's a big deal.
What's the percentage you gave for waste?
30% is what I've heard.
Yeah. It's a massive number. I mean, MedPAC was estimating $6 billion just in low-value care. That's not even waste. That's care that's appropriately given, but just not much back for it. Sue, you would say something?
Yeah, just talking about fraud and waste, from a little different perspective. I mean, charging Medicare for care that caused harm is fraud.
Yeah.
And we know that in the United States, a very small percentage, maybe 5% of harm gets reported. Yeah. So think about, fraud is really a patient safety issue because when we don't know about that harm is hidden. We need to see that harm. Yeah. And so we are paying for billions of dollars of care that has harmed patients. So I think we can reframe thinking about fraud and waste as a patient safety issue. We're not learning from it, and we're paying for it. Matter of fact, for my son who was harmed, guess who's paying for it? CMS, the state of Idaho, and I am.
Yep. Yeah, excellent point. And that would be really helpful if we can get that message out today. Brian, clinicians, of course, we are horrible at policing each other. Right? You have a civic responsibility to protect your patient, to advance the field, which we do well. But the third thing that a professional has to do is to police the field. And that's just not in our DNA. We're not used to doing that. So how do we get docs also, they're not tattletales, they're not snitches. They should be, however, part of the fabric to prevent the fraud that hurts patients.
So with my lens, certainly using AI as a tool is going to be enormously helpful in that space. Previously, we had done some work with the state of New Hampshire where we had access to a lot of the claims level data. And when you have access to that kind of data, like I know CMS and Amy, you have, the ability to train models to be able to detect those signals from the noise. And then the important step is once you have a model that's trained, that's able to be a helpful co-pilot to a physician or to a hospital administrator, is deploying that in the workflow at the point of care to help those providers, essentially maybe police themselves or police each other. I think that starts in partnership with the EHR vendors where you bring those alerts from those models that are trained or tuned to identify, potential wasteful, harmful, fraudulent bills, and catching them before they even, are paid out. I think that kind of forward deployment of AI tools starts with training models on the data, having the kind of AI sandboxes where you can bring the innovation community into CMS. And having 13 engineers, that's hard, Amy.
Yep.
So you're partnering with other companies to be able to train those models, and then you can forward deploy them with Epic, with the other EHR vendors.
I'd also add that I think when we do get to this digital identity standard, having providers use that for the provider directory also validates their identity. And if you start to use that, it'll catch fraud that way. And then giving patients the ability to report fraud through our tools that we're building is another way. In my other hat in DOGE side, I have gotten thousands of letters from patients saying, I think this is Medicare fraud.
Yeah.
If we give them a digital way to do that that's easier, I think can catch
That's
a lot
that
of
bidirectionality where patients really want to teach our healthcare system when things go wrong.
Yep.
There's no place for us to go with that data, and we actually need to open that up for patients to report harm events so we can learn from that.
Yeah.
100%.
If I could just add, I think there's also I think there's also potential for AI to be used on the CMS side in terms of looking at what's coming, what looks out of the bounds, what looks exceptional. In financial sector, I've traveled some of the banks, and they've got real time, things looking for it. Hey, this particular thing looks not right. Typically, a provider has these many patients, and this particular provider has 100 times more patients.
Yep.
That ought to flag, or the type of activity that's happening. So, Amy, I'm sure your 13
Yes.
engineers are also looking at that side as well to continue
Yes,
to
for sure.
use.
Well, I just leave you with the metaphor from the banking industry. And there's some metaphors that we want to try to emulate from other sectors. But in banking, they found that AI was a much, much better and effective tool for reducing fraud in bank. And the reason is that bank managers are not fraudsters, usually. So their minds don't work the way that fraudsters work. So they really couldn't catch the bad guys because they wouldn't have been in the same ballpark. Whereas fraudsters can understand how bank managers think because they're trying to do things that are around their jurisdiction. It's the same for us. I don't think we are natively good at identifying fraudulent behavior. Certainly doctors aren't. I don't think patients are always looking for that either. But if we can actually use AI to give us the clues, it'll be just like in banking, a much more efficient way of emulating. Because when foreign governments are involved, and they are, when foreign governments are trying to hurt America and they're using CMS to get to our most vulnerable to steal from us, it's a rich place to go. So I have one favor to ask of all of you, besides speaking up and talking to folks from CMS when you run into them in the hallways, share your ideas. I want to get a team photo. So I got permission, papal dispensation. The 5 panelists are going to come stand there. Don't get up. And we're going to get as wide a photo as we can. There it is. Lights coming on, turn the backlights off. We're coming down. God bless you all. Thank you.